So moving on, our next panel, panel number 1, is on aging. The moderator is Professor Cynthia Chen from the Swee Hock School of Public Health at National University of Singapore. Professor Chen is an assistant professor and a fellow at the Schaefer Center for Health Policy and Economics at the University of Southern California. Her research focuses on the well-being of older adults, healthcare financing, economics of aging, and biostatistics. She's intrigued by how economic, technological, demographic, and social changes can affect the burden of care, financing needs, and resource allocation. Her research has been supported by the Singapore's Ministry of Health, Ministry of Education, the U.S. National Institutes of Aging, and the Thai Health Promotion Foundation, among others. To date, she has published more than 30 internationally peer-reviewed journal articles, and she obtained her PhD in public health and a master's and BSc in statistics from NUS. Thank you so much, Professor Chen, for joining and for moderating our session on aging.
Thank you so much, Melissa, for the kind introduction. Hi, everyone. Good morning. And for those who just joined, welcome to the APRU Global Health Conference. This conference is organized by the Fudan University and the APRU Global Health Program. My name is Cynthia, and I'll be your moderator for this exciting panel on aging. Please feel free to share the conference on social media. Kindly refer to the details in the Zoom chat below. The format of this panel is similar as the previous one, where each presenter will have 13 minutes to present. This is then followed by a 10 minutes question and answer all the way at the end. After all speakers have finished their presentations, they will answer the questions that are posted. So kindly post your questions to the speakers throughout this panel using the Zoom question and answer function. This will allow time for the speakers to respond and also kindly indicate your institution as well. So the organizers have really lined up a panel of experts in this session. We have Professor Indri from the University of Indonesia, Professor Fu Hua from Fudan University, Professor Angelique Chan and Dr. Ed from the University of Singapore. Without further delay, let me welcome our first speaker for this session. Professor Indri is the head of Occupational Health and Safety Department, University of Indonesia. Her research interests are in ergonomics, human factors, aging, and safe transportation. She was awarded Best Paper in the APRU conference just last year and an oral presentation on Occupational Health conference this year. Professor Indri has also published multiple journals in the fields of anthropology, public health, occupational health, prevention, gerontology, and geriatrics. She also wrote a book on Indonesia 4 risk assessment tool and the health promotion in the workplace. The title of her talk is on comparison of workers' perception and the caring burden on handling elderly family members with dementia in Indonesia rural and urban areas. Professor Indri, please.
Thank you, Prof. Cynthia, for introducing me. Okay, let me share my PowerPoint with. Okay. Okay. Now, can you see my screen?
Yes, you just need to, to make it bigger for the presentation.
Yeah, please, wait, I will. Yeah, okay. Thank you. Well, good morning, ladies and gentlemen. In this session, I will present my research with the title Comparison of Worker Perception and Caring Burden on Handling Elderly Family Member with Dementia in Indonesian. As the background, the number of aging population is increasingly rapidly in Asia, including in Indonesia as well. The aging double acceleration in Indonesia was predicted to be the second fastest after Brunei Darussalam in Asian country. Because of aging, the number of patients with dementia may increase also, so there are many challenges in dealing with dementia patients. In Indonesia, the number of patients with dementia was thought to be relatively small at this stage, but it may increase further due to the future aging. Besides, there is a lack of care services, limited access to medical institutions that can diagnose and treat, is also lack of sufficient information on dementia for citizens. Therefore, it is meaningful to work in Indonesia from the present stage for dealing with dementia patients that are becoming important. This current situation in Indonesia, where the economics is revitalizing and the rate of aging is also remarkable, then it is a need the policy and guideline on how to care the family member with dementia, especially for working citizens, but it does not disturb their work activity. Therefore, the purpose of this study is to compare about the work perception on how to care the elderly family member with dementia in rural and urban area. This presentation is a part of research to develop the policy brief for dementia plan in Indonesia. As the is the cross-sectional study with online questionnaire. The criteria of respondents that are above 40 years old, a total 1,147 respondents were carried out of this research, but the number of workers only 944 persons, while 67% live in urban and around 33% live in rural area. Then we analyzes only the worker. The data collected online using the snowball technique which shared on the social media from 7 until 10 July 2020, and the instruments were used to obtain knowledge on dementia and the burden of caring for the elderly experienced by the worker in community is used the Dementia Knowledge Assessment Scale or DKAS and Dementia Burden Care Questionnaire. The DKAS consisting 27 questions that provide a reliable and preliminary felt scale of dementia knowledge across a range of domains relevant to clinician, educator, caregiver, and student. Indonesian version for DKES is used to identify the level of knowledge about dementia that consists of 4 domains, is namely causes and characteristics of dementia, communication and behavior, care, consideration and risk, and health promotion. Respondents answer on modified Likert scale with 5 response options: false, probably false, probably true, true, and I don't know. Okay, this is the results. It's found most age group respond 40 until 44 years old is about 36%. Then follow age group between 50 until 54 years old for 31%. And around 71% the educational background is graduated from university or from college. The type of occupational category, the most percentage as private employee is about 27% and as civil employee 25%. And the other categories were self-employee or entrepreneur, professional, and operator. The number of work hours is found 59%. The respondent work more than 8 hours per day, and 82% they work not in office, or majority the respondent work in the outsides. And then it's also found most of them, about the 71%, already exposed the information about dementia, and the majority they know from media electronics is about the 48%. Other information they got from mass media, leaflet, poster, conference, and workshops. Results from the DKES questionnaire is found 59% respondent had good knowledge results about the dementia. So it is less than the result of exposed information about the dementia. It means the information is insufficient even for many media already informed about dementia in Indonesia. If we see the results for each domain, it shows the respondent had poor knowledge in all domains of DKS. It presented 67% poor in terms of cause and characteristic of dementia, 69% in domain of communication and behavior, 74.5% they poor knowledge in care consideration, and 71% poor in the risk factor and promotion for dementia. Also found about the 59% respondent had elderly in their family member, and 40.6% respondents said had more than 3% of elderly in their family member, and 58% stay with them. Okay, the elderly at the most was their grandfather and grandmother. But the majority of grandfather and grandmother had dependency in their daily life activity, but mostly the dependency category was mild. However, we also found the elderly member was grandfather is so the dependency about 51% categorized was total care. And then we would like to see how about the respondent is the worker, they help or not the elderly family member. It's found 74% respondent help their family member, but 26% did not help. So they asked other family member to support it, such as their brother, sister, spouse, child, and their house assistant. Okay. This is the bivariate analysis. It shows there is some related factors. There were 4 factors, so significant difference between respondents who live in urban and rural area. The first, those within the age group 40 until 44 years old is tend to live more in urban than in the rural area. The second, the type of occupational is also significant difference. More private employees situated in urban area, while in rural area, the occupational mostly as civil servants. The third, their working hour, where those in rural area tend to work 8 hours a day. In terms of obtaining on information related with the dementia, as the last factor had significant difference between respondents living in urban area, more exposed information than those living in rural area. Meanwhile, there were some factors not significant difference, such as type of working location, their elderly family member, the relation of elderly family member, how to carrying them, the dementia knowledge by the KES, and supported the dependency elderly between rural and urban area also found not significant difference. The conclusion, the research showed that the respondent characteristic of those living in urban and rural area have significant difference, particularly in the occupational type, more private employee in urban area, while the rural area most as the civil employee. Then the work duration per day in urban area is longer than 8 hours. The information of dementia, there were more information in urban area and than the rural area. The factor had significant difference between workers who live in urban and area. But in terms of DKES results, support elderly family member, dependency elderly for those living in urban and area for not significant difference. However, in Indonesia, by Minister of Health has launched the National Strategic for Management of Alzheimer and other dementia disease toward healthy and productive older person in 2005. The strategic are mainly focused on the management and prevention. The public awareness is stressing on healthy lifestyle program. But none of strategic is addressed to public awareness about the dementia as the whole sets of cause and characteristics, communication and behavior, care consideration, and the risk and health promotion. So it will be another focusing for our governments to make the policy brief about the dementia. Okay, this study had ethical clearance and financial support from University of Indonesia. This is the reference. Okay, this is all my presentation. Thank you so much for your kind attention. Prof. Cynthia is back to you.
Thank you so much, Prof. Andre, for your inspirational sharing on the caring burden in Indonesia. So our next speaker is Professor Fu Hua. He's the director of Health Communication Institute, School of Public Health, Fudan University. His research interests are focused on healthy aging, setting-based health promotion, especially healthy city programs, non-communicable disease prevention. He is also the vice director of Shanghai Association for Health Promotion, and also the PI of the National Best Course and the team leader for co-sharing courses on preventive medicine in China University. As chief editor, he published textbook on preventive medicine for medical students and another on science and health education, theory and practice in healthy city. The title of his talk is on asset-based approaches for functioning of older adults in China. Professor Fu, please.
Okay, thank you, Professor Chen. Good morning. Thank you, Professor Chen. Good morning, ladies and gentlemen. This is my pleasure to join the 14th APRU Global Health Conference and share our work about the health aging with you. The title I'm going to present today is the asset-based approach for functioning of the older adults in Shanghai, China, which was co-contributed by our team, Dr. Yebo, Chen, Hock, and Gao Junling. Facing the rapid development of the aging population, the 73rd World Health Assembly have endorsed the proposal for a decade of the health aging in August of this year. Health aging focuses on developing and maintain the functional ability that enable well-being in old age. As we know, in the traditional thinking, we still consider how early diagnosis, treatment, and manage disease through the service providing. How could we promote the health aging, especially in the public health pathway, is still change in China. And a asset-based approach in health promotion field might provide a new way. Asset-based approach counter deficit-based approach to assessing health promotion need. They focus more on the positive aspect of the health and what makes us healthy, rather than on what makes us sick. Assets are defined as the collective resources which individuals and communities have at their disposal, which protect against the negative health outcome and promote the health status. These assets can be social, financial, physical, environmental, and the human resources. For example, employment, education, and supportive social network. There are a number of the challenges in using and developing asset-based approach, such as how to assets are measured, establishing the relationship between the asset and well-being in a culture that has been more concerned with the major ill health and disease. So our research objective and framework is to explore the evidence on the community assets related to the elderly function through the understanding the association between the neighborhood environment and the variety and analyzing the interaction, community level and factor and the individual level factors. We use the aesthetic quality and working environment, social cohesion and social participation as a community's physical and social assets, as well as the variety and well-being as the outcome indicate. As you know, many studies have demonstrated that variety is an effective predictor of the early disability. The present study was conducted in Shanghai. Totally 2,131 older adults aged over the 60 years old was selected by stratified random sampling method and interview with the questionnaire. The final, there are 2010 valid questionnaire for the analysis. The present study, this slide shows the contents of the questionnaire, such as the lifestyle, neighborhood environment, variety, well-being, and others, such as the self-support health and the W5 scale. So first, I will present our research result. This slide shows the basic information and the distribution of the demographic characteristic and the lifestyle by gender among the elderly. As you see from the table 2, and the proportion of the never physical activity in the male was more higher than the female. And the table 3 showed the variety domains distributions. From the table 3, we can see that the fatigue and the resistance had a highest the proportion in this the 5 domain of the variety. If we divide the variety into the 3 categories, robust, peripheral, and the frail, we can see that the frail state was accounted for the 15.5% in these all the participants. In terms of the distribution of the frailty, female higher age group and the non-married tends more frail state, as so in the table 5, and less the vegetable intake, less fruit intake, and physical inactivity tends more frailty in the table 6. And table 7 and figure 1 show the relationship between the frailty and the neighborhood environment factor. And from this the table and figure, we can see that the negative association between the frailty and the neighborhood environment include the 4 domain. It means the aesthetic quality, working environment, social cohesion, and social participations. The multi-level analysis, it means that we considering the multi-level and individual levels. So the older adult who live in a higher working environment neighborhood had a 40% lower risk of the frailty than those who live in the poor neighborhood, as we see in this the table A. And the higher social cohesion may have a strong role in protect older women from the frailty, as so in the table 9, and this the figures. When we also consider the interaction of the frailty and the drinking, table 10 shows that with higher social cohesion, older people drinking behavior was associated with the higher risk of the frailty. And table 11 showed the better working environment partially compensate for the lower subjective well-being of the frail elderly. So it means the better working environment as was demonstrated as a health asset for the frailty older people. So this slide shows a result about the structure education modeling of the well-being. It shows that the neighborhood environment, physical activity, and the health state can explain the 48% of the variations of the subjective well-being. So let's, in conclusion, so from our study, there is the significant correlation between the community level working environment and frailty in the elderly, and in the individual level, aesthetic quality and the social participation were also independent associated with the frailty. There are interaction, in fact, between the community environment and individual factor which influence the frailty. Higher quality of the working environment as a health asset may compensate for the negative association between the subjective well-being and the frailty. So the present study provides scientific evidence for the policymaker and the public health community, and demonstrate that asset-based approach to the providing the neighborhood environment should be advocated for the positive, promoting the function and subjective well-being of the elderly, combining with the managing the health behavior and ill health conditions. In fact, neighborhood environment improvement is not only benefit for the elderly, the older adult, but also to other age group. So it would be great help to the universal health coverage across the life course. Thank you very much for your attention.
Thank you very much for your sharing of the inspiration research on asset-based approaches on well-being in China, Professor Fu. Our next session will be a joint presentation with two speakers from the Center for Aging Research and Education, Duke NUS Medical School, the National University of Singapore. They are Professor Angelique Chan and Dr. Ed. Professor Chan is Executive Director of the Center and holds joint appointments as Associate Professor in the Signature Program in Health Services and Systems Research. Professor Chan's current research examines disability transitions, mortality, the effect of social support on health, caregiver burden, and the use of long-term care services. She has published widely on aging issues in leading international journals, and also co-author of the book titled Aging in Singapore, Service Needs and the State, and also co-editor of Ultra Low Fertility in Pacific Asia, Trends, Causes, and Policy Issues. She is also consulted by local ministries such as the Ministry of Health, Ministry of Social and Family Development, Temasek Foundation, as well as international agencies such as the World Bank and the United Nations. She also sits on various national committees on aging research and education. Dr. Ed is an anthropologist and also research fellow at the same center who specializes in cultural concepts of health and aging, and also expert in training qualitative research methods. She has conducted several evaluation studies focusing on user experience in community health services and the factors impacting quality of care for vulnerable elders. Dr. Ed believes that the wisdom and empowerment of our elders by exemplifying their stories and advocating for inclusive, passionate, and just society for all ages. The title of their talk is on evaluating the community health and social care project, translating research into policy. Prof. Chan and Dr. Ed, please.
Good morning, everyone, and thank you for attending this session. Today, I'm going to be talking about a community health and social care program that the Singapore government is piloting. And the development of community health and social care is extremely important given the aging of our populations. We can no longer require on hospitals providing all of the care for older adults. We really need to devolve care into the community for sustainability. Next, please. Singapore is aging very quickly. If you look at the bar chart, you'll see that Singapore is second to South Korea, the Republic of Korea, in terms of the speed of aging. And by 2050, about 21% of the Singapore population will be above the age of 65. Now, in addition to this, our dependency ratio has been declining over time. One older person used to be able to rely on 31 working age adults in 1970, and currently it's about 1 in 4 in terms of the old age dependency ratio. Next, please. So when you look at integrated care and the way in which health and social care is delivered, you can think about the types of older persons that we would be interested in. So the diagram on your left shows older persons starting off, being very fit and well, managing well, even if they have chronic diseases or they need to recover from surgery. And for this group in Singapore, they're pretty much covered by senior activity centers, active aging hubs, and the program that I'm going to discuss today. When you move into the group 4, which is vulnerable elderly and the mildly frail, moderately frail, then you start to see other types of services stepping in. The active aging hub services do cover them, but senior care centers come into play. The Care Close to Home program continues to serve this segment of the older population. home care comes into play, and home medical, home nursing, home therapy, escort services and transport for medical services, Meals on Wheels, and what we have called an integrated home and daycare package. And then a variety of caregiver support services come in, including care assessment and community care management. Then at the tail end, for the very severely frail and the terminally ill, they're pretty much relying on home health services, help with transportation, Meals on Wheels, and a lot of caregiver support is provided. So healthcare is related to treatment, control, or prevention of disease and disability, and it involves caring for a person with unmet needs in these areas. Social care refers to assistance with activities of daily living and any kind of care that helps older adults maintain independence, social interaction, that helps older persons to remain very engaged with society. It helps manage complex relationships, and also helping with accessing to services that are required by the older person. Next. So the combination of providing health and social care needs is a relatively new concept. In the past, health services were provided in isolation, and social care needs were provided alongside, but they weren't necessarily connected. The current thinking on this is that if you can provide services for health and social needs that are integrated, you essentially get more higher quality of care. You'll cover more areas in the older person's life that need attending to. And because you know both the health status and the social needs status of older persons, you'll be better at assessing what kinds of services would be suitable for older adults. Now, this program that we are discussing today focuses specifically on older persons who are identified at high risk for readmission into hospitals, older adults who are in a lower socioeconomic status, and older adults who are living alone for the most part. So in 2016, the government started to pilot this care close to home intervention, and the program elements included the provision of home personal care, nursing services, and other services. And these are indicated in detail on the colored buttons below. The team involved was a registered nurse and at least 5 healthcare or nursing assistants. And the overall aim was to maintain function of vulnerable older adults and allowing them to age in place by providing home personal care, nursing services, and other services. And the idea was to embed a care team in the community. Next. So in the study that we did in our evaluation, we had 3 research questions. We wanted to know if older adults enrolled in the program performed better in terms of a series of outcomes, including social engagement, loneliness, social networks, depressive symptoms, quality of life, compared to those who were not enrolled in the program. And then we wanted to know if the intervention addressed specific clients' unmet needs. And finally, what were the barriers and facilitators to meeting unmet needs? Next. So the reason that Dr. Malud and I are presenting today is because we did a mixed methods evaluation, and I think this was, critical to the evaluation success. We started off with a qualitative evaluation to try and identify clients' needs and understand the psychosocial impact of the program and the barriers and facilitators to meeting needs. On the basis of the qualitative data we collected, we then developed a survey questionnaire, and we administered the survey to persons who were in the intervention group and those who were not. and then assessed whether clients' needs were met. We had 125 respondents in the intervention group and 254 in the control group. Next. To cut to the chase, in terms of the quantitative evaluation, stress on quantitative, we did not find any significant difference in the outcome measures between the control and intervention groups. So in terms of functional outcomes, ADL, IADL, and number of chronic conditions, there was no difference. And also in terms of psychosocial outcomes. Next. In addition, we found that there was very low program awareness among the intervention group, and that there was a misalignment between what clients actually needed and the types of services provided. For example, blood pressure monitoring was conducted weekly for 90% of the participants, but only 60% reported being diagnosed with hypertension. And finally, there was very little impact on the psychosocial outcomes, because even though psychosocial outcomes were identified as an important income, what our survey data showed us was that activities were limited to brief conversations, medical advice, mediation of family issues, and the average dosage was 30 minutes per quarter. Next. So at the end of the quantitative evaluation, we sort of went back to the drawing board, and we spoke with the programmers, and we said that, you know, really, if you want to look at these kind of clients, medically complex, socially complex, frequent flyers, you really need to assess needs at the very beginning. And based on that, create a plan to address the needs, implement it, and then evaluate it. And you need to have outcomes that are based on things that you're interested in, not on how many times blood pressure was measured, but whether you lowered mortality, whether you lowered number of hospitalizations and emergency room visits. Next. I'll hand over to Ad now. The qualitative analysis gives a story to the numbers.
So hi, so this is what the corridor of a public rental housing estate in Singapore looks like. When you open the door of your house, you can almost immediately see the inside of your neighbor's house. Yet there's plenty of news reports about lonely elders living in these rental flats. So actually doing a mixed methods evaluation gives us a user's perspective as to why the program had limited psychosocial impact. We asked participants a few questions to understand what affects their well-being. So what we found is that there was an issue of pain and mobility. Participants expressed difficulties coping with pain and functional limitations, so they expect services that offer ADL and IDL support as well as pain management. Second, in terms of income, they expressed anxiety securing needs such as healthcare, housing, and paying utility bills, so they expected services to be free and accessible. Third, they express a desire to be meaningfully engaged, suited to their abilities, so they expect services that are engaging, meaningful, predictable, and reliable. To illustrate the common challenges faced by active clients, meet Madam Whitehair. Let's call her that. She has a lot of things to worry about. She thinks her life is tragic. No amount of painkillers can help ease her pain. She no longer feels joy in her life, but she wasn't always like this. So this was an important point she and other participants made, that they were the ones others rely on for help, not someone who needs to depend on others. She also used to volunteer at the Senior Activity Center, but now she's confined to the four walls of her home because she has difficulty walking and standing. We use Madam Whitehair as an example because if C2H works for her, it might work for a lot of other clients, many of whom share her experiences and challenges. However, C2H did not work for Madam Whitehair. So let's find out why. Policymakers acknowledge that proximity to healthcare services would enable better support for vulnerable older persons living in public rental housing. But what does care close to home actually mean for these residents? In our interviews, participants talked about upstairs and downstairs. This differentiation is actually very crucial to what they expect out of community intervention. So we have home, which is upstairs, that they associate with comfort, sense of control, privacy, but there's also pain. Pain keeps them at home and therefore makes them lonely and bored. Then we have the downstairs. It's where things or social activities happen. There's a lot of exercising, there's nurses and professionals there to help, but there's also gossip. Our older clients fear gossip, so they will retreat back upstairs. They're ashamed that people will see them as useless and a burden, or that they are sick and so weak that they go back upstairs. So what C2H intends to do is to actually bridge the upstairs and downstairs through trust and relational care. So a good program is one that makes the movement of care seamless from upstairs to downstairs and downstairs to upstairs for the more vulnerable residents. However, in our interviews with users and providers, we found three main barriers to delivering seamless care. They are operational, communication, and unmet needs. To summarize, for operations, there's an inadequate manpower supply and shortage of competences related to dealing with complex case management. For communication, since a lot of our healthcare aides are foreigners, there's also language and cultural barriers, as well as a lack of transparency in communicating expectations. Further, unmet needs. C2H services at its current state are not adequate to support clients with more complex needs such as high levels of disability, depression and suicide ideation, homelessness, and financial issues, as well as those who are severely lonely and isolated. So is C2H better than doing nothing? So we found that in quantitative research, there's no difference in terms of outcomes. In the qualitative research, we found that those who reported positive impact tend to be those who are already having reliable support networks, they are participating in social activities, and they were more ambulant compared to those who felt that there was no impact. So C2H is useful and important to support the needs of vulnerable elderly. However, its potential values to address psychosocial and functional needs are largely hindered by manpower shortages and skills competences to engage clients with more complex needs. So we came up with this social model of care that we've shared with the ministry based on 4 key components: client engagement, operations management, care ecosystem, and community engagement. The colors, the fonts that is in green shows what is currently being done and achieved. The amber is what's in progress, and red is what needs to be done. So Angelique will wrap up the presentation.
In one slide. So if we want to translate research findings into policy, of course, the first thing you need to do is communicate your results to stakeholders. And we did this and then gave them a recommendation that we needed to address that black box that I showed you earlier, where you assess needs, then develop a protocol to address the needs, and a process of implementation, which includes assuring that there's manpower and skills competency, and then assuring that the types of outcomes being reported are the types of issues that the program is trying to address. So critical gaps in program development, this is our take home, is that you really need a holistic and standardized needs assessment, and protocol development really needs to promote service matching, identification of causal and contextual mechanisms driving outcomes, and ensure that these programs are able to be replicated and scaled. Thank you very much.
Thank you so much for the sharing of your research in Singapore, Prof. Chan and Dr. Mahmood. So due to time constraint, I will try to keep the questions to maybe one per speaker. So for Professor Indri, I think there are some of the questions that are in the chat. So maybe I can read out one of it. So one of the participants, Jita, was asking, are there gender and education disparities in your research?
Okay, thank you for the question. The result that I presented only for the worker respondents is 994 respondents. So I cannot find the significant difference between gender, educational background among workers in urban and rural area. However, when we analyze the all data of respondent, 1,147 for worker and non-worker, I can find there is a significant correlation between gender, educational background, and occupation with the DKES results, or with the perception and knowledge of the dementia.
Thank you.
Thank you.
Could I trouble you to maybe respond to some of the other questions while I move on to the next speaker? Okay. Professor Fu, thank you so much for your sharing also. So I was wondering, Many countries do have resource constraints with regards to implementation, and in the asset-based approach in improving neighborhood environment, what should countries really be focusing on? Should it be physical environment, the social environment, or what would give us the biggest bang of the buck given the resource constraints that we have between countries?
Thank you. And I think that in our traditional thinking, we most, especially in our medical field or the traditional public field, when we talk about the aging or the elderly, we maybe by think how can we provide the service for them to help them. But I think that when we from the disease seek to function and also to well-being, maybe we can consider what is the positive factor to promote for this. I think this maybe it is the philosophy change. So I think for example, maybe we can, for example, we have some green space and also, but we don't know this, the green space is helpful for the elderly or not, because maybe we can think they may be the people's older and older, then maybe they cannot share the environment, but it's not true. So I think for the policy maker, we should provide the evidence for them, and especially in the city level or the community level, to how could we improve the environment, especially the neighborhoods, and they just close their home and promote the functional ability. I think it's much important. But of course, it's difficult. For example, for only on our public health professional, we cannot do something. Maybe we cannot do something, but we should advocate for the other sectors and also for the city, the civil, the planning, and how to advocate. They join our the effort to promote the health aging. I think it's much important for our change, our philosophy. Thank you.
Thank you so much, Professor Fu, for your sharing. So there are a few questions to the final session. Maybe I just direct one to Prof. Chan and one to Dr. Mahmood. Prof. Chan, I think from Haytham, there's a question that asks, based on your experience in doing research in Singapore, how can aging researchers seek to obtain meaningful impact from their work?
Okay, I'm not exactly sure what you mean by meaningful. Is it meaningful for you or meaningful for others? But I'm going to take it as meaningful for others. I think what you need to be able to do is really show the positive and negative aspects of your findings very clearly. And in the case of what I just presented, we also wanted to show the positive and negative aspects of using certain methodologies. So quantitative methodology surveys could only tell us so much. And by combining qualitative work, we could really see the story behind the numbers.
Right. Thank you. So maybe I'll follow up on that. There's another question on the C2H program, and maybe I direct it to Dr. Ed. So there is a socio-economic aspect of older adults, caring for them, and as well as the cultural aspect. So from your research, how do you think we could make them more accessible? This is a question from the participant.
Yeah, hi. So to make the cultural aspects more accessible is to also understand culture is what gives us meaning, is what we hold on to, is our values. So in a sense, older people, they still want to feel as if they can still contribute to society. And one way they do so is to express themselves through meaning and through language and meaning making. And this is limited if basically their service providers do not speak in the same language as them. So one of the ways in which some other countries have put forward is to have some kind of cultural exchange or cultural immersion program where we get foreign nurses or foreign healthcare aides to come into the community, learn the language for 1 year, interact with their clients before they actually begin the service proper, or while doing it in terms of on-the-job training. So this is something that we have not yet explored in Singapore, but it's done in terms of like ad hoc or like piecemeal basis, but not in terms of an integrated like solid program where we actually create cultural exchanges between those who are culturally different from the clients that we spoke to. Yeah.
Thank you so much, Dr. Ed. Let me express my thanks to really this panelists for this exciting aging session. I also like to thank the participants for your thought-provoking questions. However, due to time constraints, there were really more questions than we could take. And I invite the participants to really follow up with the speakers directly on your questions. We really hope that this session is helpful for all who have attended. And for those of us who like to revisit the materials, the recordings, the slide, I believe it will be shared on the website, apru.org, after the conference. So right now, I hand over to Melissa to wrap up today's session. Thank you.
Thank you so much, Professor Chen, and to all of our speakers. Really, really fascinating work on aging.